Miss Inowemem Opopo. I'm a second-year resident at Florida Atlantic University Internal Medicine Residency Program. Today, I'm happy to discuss a case of recurrent pancreatitis as a complication of pancreatic divisum, which in itself is a relatively rare pancreatic anatomic anomaly, typically seen in about 2 to 10% of the general population. I'm going to initiate this conversation by presenting a 64-year-old female with a history of chronic alcohol use as well as inflammatory bowel disease who presented with initial complaints of abdominal pain and emesis. Her lab work at the time showed normal triglycerides, however, lipase and amylase were noted to be quite elevated. Abdominal ultrasound ruled out evidence of gallstones, and a follow-up CT abdomen showed pancreatic inflammation with several cystic appearing fluid collections. Patient was at the time treated conservatively with IV hydration and pain control. Given persistent abdominal pain and nausea vomiting, a repeat abdominal CT done a couple days later revealed multiple increased peripancreatic fluid collections with mass effect on the stomach. A persistent abdominal pain led to an ARCP which showed complete pancreatic divisum with high-grade pancreatic duct fistula in the body and tail of the pancreas. She underwent sphincterotomies, which were done with stent deployment in each duct. A follow-up EUS revealed 3 peripancreatic fluid collections consistent with ward of pancreatic necrosis, of which the largest was adjacent to the gastric antrum. With incision, there was purulent drainage noted. Therefore, patient was initiated of antibiotics with meropenem at the time. She had recurrent pancreatitis, for which she had repeat minor sphincterotomies with dorsal pancreatic duct stent exchange, of which the patient, following these interventions, made good improvement, and prior to discharge was actually tolerating low residue diet with minimal nausea. As you can see on these images over here, Figure 1 shows a cross-sectional view of the CT abdomen showing those peripancreatic fluid collections, and Figure 2 shows the same collections, but also you can appreciate the mass effect noted to be on the stomach. We thought this case was quite interesting given the patient's clinical progression. Necrotizing pancreatitis has a complication of ward of pancreatic necrosis, which typically occurs after 4 weeks of the initial insult. It can cause obstructive symptoms as noted with our patient, with persistent nausea and vomiting. We suspect that our patient had recurrent pancreatitis, which was mistaken as a flare-up of her IBD by her primary physician on an outpatient basis, and it's likely that her use of alcohol predisposed her even more so to having these pancreatitis episodes. Although the risk for pancreatitis is the same in pancreatic divisum patients as with the general population, some studies have shown that they might be at increased risk of having recurrent pancreatitis, for which they should be intervened with sphincterotomies, dilation, and stenting in appropriate cases. It is important to detect pancreatic divisum early to allow for interventions and minimize frequent recurrence of pancreatitis, which in itself can lead to chronic pancreatitis as well as pancreatic insufficiency. Finally, it is important to follow up with images about 3 to 6 months following the pancreatitis so as to exclude any underlying neoplasm which might also lead to further pancreatitis down the road and worsening of symptoms. Thank you all so much. Have a good one.